Hello. In this lecture video, I am continuing under pharmacology. I had we had started looking at the principles of pharmacology, and so in this recording, I conclude that particular lecture. Now, you will note that we had started by covering pharmacotherapeutics, and we had discussed rational therapeutics as well as empirical therapeutics. Then we had moved on to look at pharmacodynamics, where we had discussed basically the biochemical and physiological processes that the drug will actually initiate once it is introduced into the body. We had said pharmacodynamics basically looks at what the drug does to the body. We had talked about how the drug may work via enzyme interactions. We had talked about how drugs can work via receptor interactions as well as non-specific interactions. So in this recording, I begin with looking at another principle of pharmacology, which is basically pharmacokinetics. So, pharmacokinetics is actually a compound word. You can see it has pharmaco and then it has kinetics. So, pharmaco relating to drug, and then kinetics is actually derived from a Greek word, kinesis, which means movement, meaning that in pharmacokinetics, we're basically looking at how the drug moves through the body, but basically its time course, okay, the time course of the drug from absorption, distribution, metabolism, and excretion. In other words, pharmacokinetics basically looks at what the drug does, what the body does to the drug. So the body will have to absorb this drug, it will have to distribute it so that it can reach the target tissue, and then it will have to metabolize this drug and eventually excrete it. So in order to achieve the desired pharmacological response, the drug firstly must be available in a suitable form, and then it must be given via an appropriate route. I think I had indicated earlier that drugs have formulations, and these formulations are designed to be administered via certain specific routes. So you find that if a drug is designed for parenteral administration. For example, gentamicin. It is designed for parenteral administration. If you administer gentamicin orally, then it is not stable. It is not stable in GIT contents, meaning the drug will actually be destroyed by the low pH and other factors within the GIT. So the drug must be administered by the right route in order for it to actually reach its target sites and exert its effects. So let us move on and look at the specific pharmacokinetic parameters that are actually considered when we are discussing drugs. So you will note that every drug that is administered, when we talk about pharmacokinetics, we should talk about its absorption, its distribution, metabolism, and excretion. So what is absorption? Absorption is basically the process by which a substance enters the blood circulation. In this case, we're referring to the process by which this drug will be absorbed into blood circulation, okay? And so that it can become available to the tissues for utilization. So from whichever surface or from whichever part of the body the drug is administered, it has to be absorbed, it has to enter blood circulation, and that is what is called absorption. So there are a number of factors that influence the rate of absorption. Some of these factors include the route of administration, okay? So whether a drug is administered intramuscular, intravenous, or sublingual will influence how quickly this drug will be absorbed into circulation. Another factor is the solubility of the drug. You will note that certain drugs are actually lipid soluble, and so those drugs that have a high lipid solubility, you find that actually even the distribution of that drug will actually be good, and even when it comes to the volume of distribution, you may find that it will have a high actually volume of distribution. But solubility, this drug should be able also to disintegrate easily once it is in the tissues where it has been introduced, whether it is orally, it should be able to quickly disintegrate. And then if this drug quickly disintegrates, the solubility is high, then the rate of absorption will actually be high. Absorption will also be influenced by presence of certain body conditions. So, for example, if you administer a drug orally and a patient has diarrhea, it means that the absorption of that drug will be impaired because, um, for example, if it's in capsule form and it doesn't the capsule does not dissolve quickly, you find that in certain conditions like cryptosporidiosis, even the entire capsule may actually be excreted uh, through feces without actually being dissolved. So certain body conditions will affect the rate of absorption. And another example would be dehydration. If a patient is dehydrated and then you administer a drug subcutaneously, the absorption of that drug will be very slow because blood supply to that particular area of the subcutis will be limited. So all such factors may actually affect the absorption. So drugs are most rapidly absorbed when given via the intravenous route, followed by the intramuscular route, the subcutaneous route, and lastly, the oral route. So if we need to administer a drug to achieve a quick effect, then we should consider those drugs that can be administered via the parenteral routes, okay? Because it is faster in terms of absorption. So some drugs are more soluble and thus are absorbed more rapidly than others. Now, there are three very important pharmacokinetic parameters that we're going to discuss: bioavailability, volume of distribution, and the clearance of this drug. So let's look at the bioavailability. So bioavailability is the percentage of the drug released from a formulation that reaches the systemic circulation and becomes available for exerting a biological effect. So when a drug is administered, let's say a drug is administered orally, remember that from the GIT, the drugs will first be, or whatever is absorbed, will first be taken to the liver. So in the liver, there will be a certain amount of the drug that will be made inactive. Then a certain amount or a certain percentage will then be released into systemic circulation in its active form, meaning that that amount of the drug that has now reached circulation is what we are referring to as bioavailability. So the percentage of the drug released from a formulation that reaches systemic circulation and becomes available for biological effect, that is bioavailability. Then factors that are actually able to affect GIT absorption, because those will also affect the amount that will become available to the tissues to exert an effect. Stability in gut contents, okay, disintegration time. So if a drug is unstable in gut contents, like I mentioned earlier, then the rate of absorption will be slow. And then if a drug does not easily disintegrate, okay, from whichever formulation, whether it's a tablet, whether it's a capsule, if the drug does not easily disintegrate to release the active ingredient or the active forms of the drug, then the rate of absorption will be slow. Rate of dissolution, I had already explained this one. The pH of the gut. Certain drugs require a very low pH in order for them to be absorbed well. For example, tetracycline, okay, such as doxycycline. If you're going to administer doxycycline together with a drug that reduces the pH of the gut, then the rate of absorption of that doxycycline will actually be affected. So certain drugs require a low pH in order for them to be absorbed faster. Then the rate of gastric emptying, I had given an example of diarrhea. Diarrhea will cause a very fast rate of gastric emptying, meaning that the drug will, there won't be sufficient time allowed for the drug to be absorbed because the rate of gastric emptying is too fast. Then the surface area available for absorption. In situations where the surface area in the GIT is impaired, let's say a patient has had resection of parts of the small intestine, then it means that the rate of absorption of drugs also might be affected. But also conditions that affects the surface area of the GIT. For example, if this patient has cancer or metastases that have affected the intestines, it means that even the surfaces available for absorption will be limited, and that will reduce the absorption. Then we have what is known as first pass metabolism. This will also affect the absorption. It will affect the percentage of the drug that will become available to the tissues to exert an effect. What is this first pass metabolism? So it is the metabolism of some drugs in a single passage through the liver, gut wall, or the lungs before reaching systemic circulation to the liver. So I had already explained that when drugs are administered via the oral route, they will be taken initially before they enter systemic circulation, they'll go straight to the liver. Now, one of the roles of the liver is detoxification. So the liver will begin to break down the drug, breaking it down into an inactive form. That metabolism, which occurs before the drug reaches systemic circulation, is what is referred to as first pass metabolism. Now, also, this first pass metabolism may occur even in the gut itself. Okay, remember the gut is colonized with a lot of bacteria. It has a lot of enzymes. So all those factors will begin to may begin to convert the drug into an inactive form, so that by the time the drug is now finally reaching systemic circulation, a certain percentage of the drug will have been made inactive. So when you administer a paracetamol 500 milligrams to a drug, it doesn't mean the entire 500 milligrams will become available to the tissues to exert an effect. Some of it will have been made inactive through the gut wall, some of it through the liver, and only a certain percentage will then reach systemic circulation. Others may occur in the lungs, for example, aerosols. Okay, if one inhales a drug, uh, some of the drug will actually be made inactive within the lining of the respiratory tree as well as the lungs. So not all of it will be absorbed at the alveolar level. So some drugs are extensively metabolized in their first pass metabolism. For example, organic nitrates such as nitroglycerin and beta blockers such as propranolol. So you find that when you administer these drugs, quite a significant percentage of the drug will be made inactive before the drug actually reaches systemic circulation. Now, intestinal first pass metabolism is due to intestinal mucosal metabolism, and examples of drugs that will undergo a first pass metabolism in the intestines is actually isoprenaline and tyramine. Whereas for pulmonary drug metabolism after aerosol inhalation, isoprenaline is one of those drugs, but also nicotine. Now, the first pass effect can actually be avoided by administering drugs using the sublingual route. And also, obviously, if you administer a drug using the parenteral route, it won't have to go through first pass metabolism, and to some extent by rectal administration, because in the rectal plexus we have a lot of veins, we have arteries and capillaries there. So some of the drugs will be absorbed into those capillaries, and thereby bypassing first pass metabolism. So remember, first pass metabolism, where before this drug reaches systemic circulation, some of it or a percentage of it is converted into an inactive form, such that only a certain percentage will then be released into systemic circulation. Another pharmacokinetic parameter is the volume of distribution. So we were looking at bioavailability, and we've discussed that bioavailability is actually the percentage of the drug that reaches systemic circulation and becomes available to the tissues to exert an effect. Now, we have said the bioavailability will be affected by a number of factors, among them the absorption of the drug, and we have discussed factors that will influence the absorption of this drug, and also the first pass metabolism. We have looked at the first pass metabolism in particular, and we have discussed that drugs will in a single pass through the liver or the gut wall or the lungs, there will be a percentage of the drug will be converted into inactive forms, and that occurs before the drug reaches systemic circulation. So the other pharmacokinetic parameter that we'll look at is basically the volume of distribution. Now, the volume of distribution is a measure of the apparent space in the body that is available to contain the drug. A measure of the apparent space in the body available to contain the drug. Now, by formula, the volume of distribution is equal to the amount of the drug in the body over the plasma concentration. What does this mean? This means that um, the total amount of the drug available in the body over the plasma concentration. So if you have a drug, for example, that will, whereby much of this drug, when it is administered, much of it will be in the extravascular compartment. It won't be in the plasma, meaning the amount of drug that remains in the plasma will be very low. It means that such a drug will have a very high volume of distribution, because just for argument's sake, to bring the point home, let's say 500 milligrams of the drug is available in the whole body, okay? Whereas the amount that is available in plasma is just 10 milligrams. It means that the volume of distribution for this drug is actually 50, implying that much of the drug is in the extravascular compartment and only a small percentage is remaining in the plasma. So when we say a drug has a high volume of distribution, it means that much of the drug will actually be in the extravascular compartment, in the tissues, as opposed to the amount or compared to the amount that remains in the plasma. Now, small volume of distribution is favored by low lipid solubility, high plasma protein binding, low level of tissue binding, and then the reverse is true. What does this mean? If a drug has a small volume of distribution, it means that the amount of the drug that will be in the extravascular compartment compared to the amount that is in the intravascular compartment in the plasma is actually low. What favors a drug to have a low volume of distribution? What will cause this drug to remain mostly in the plasma as opposed to exiting to go into the tissues? What are those factors? That is why we're saying low lipid solubility. Now, if a drug has a low lipid solubility, it means it is not so much attracted, it hasn't got a very high affinity for lipids. And in the body, you have a higher concentration of lipids in the tissues, in the extravascular compartment. But then this drug is not attracted so much to the lipids that are in the extravascular compartment. So it means much of the drug will remain in the plasma. High plasma protein binding. So if this drug binds rather with a very strong affinity to plasma proteins, especially albumin, it means that this drug will be attracted to bind to the albumin within the plasma, and so only a smaller percentage of the drug will go into the extravascular compartment. Much of it will remain in the plasma. So we'll say the drug has a low volume of distribution. Then drugs with a small volume of distribution actually have a low level of tissue binding, meaning they do not have a very high affinity for binding to the tissues. Much of the drug will remain within the plasma. This implies that for a drug to have a high volume of distribution, or a large volume of distribution rather, it means that this drug should have high lipid solubility, it should have low plasma binding, and it should have high level of tissue binding. Okay? Because then such a drug will be attracted to the extravascular compartment, and only a small percentage will remain in the plasma. So the volume of distribution is an estimate of the extent of extravascular tissue uptake of the drug. Okay, we want to see how much of the drug will actually go out of plasma into the tissues. Now, small volume of distribution, for example, we have furosemide. Furosemide, it means when we administer it, much of the drug will remain within the plasma. So it has a low tissue uptake. What this means, remember that furosemide, Lasix, it's a loop diuretic. We want it to exert its effect where? On the loop of Henle in the kidneys. Now, what you can imagine, if much of this drug is lost from plasma, it goes into the tissues. It means the amount that will reach the kidneys to exert its effect will be very limited. That is why they've designed this drug to have a small volume of distribution such that much of the drug will remain within plasma so that it will be able to be taken to the kidneys to exert its effects. What about drugs that have a large volume of distribution? An example is digoxin. Okay, digoxin has a large volume of distribution, indicating extensive tissue distribution, meaning when we administer digoxin, a large amount of the drug will move from the intravascular space, from the plasma into the tissues. Only a small amount to remain in the plasma. And this is for a good reason. Remember that digoxin, this digitalis, we want it to act where, for example, on the myocardium. Okay, we want it to cause a positive inotropic effect, for example. This drug should be able to leave the plasma into the tissues so that it can exert its effect on the myocardium. Now, Why, as nurses, are we talking about this volume of distribution? One very important thing is that in case of toxicity, dialysis is not useful for those drugs that have a high volume of distribution because of extensive tissue distribution. But dialysis will be useful for drugs with low volume of distribution, where most of the drug is in circulation or in plasma. I hope this is clear. If a person is intoxicated, for example, with digoxin, digoxin has a large volume of distribution. It means that much of the drug will go into the tissues. It won't remain in plasma. So even if you connect this patient to a dialysis machine, the amount of the drug that you filter out using the dialysis machine will be very little. Much of the drug has already left the plasma. It is in the tissues. So, but if you have a drug such as Lasix or any other drug with a small volume of distribution, meaning the drug remains mostly in plasma, then when you connect the patient to a dialysis machine, you'll be able to get rid of much of the drug because it is still within plasma. What about clearance? It's another pharmacokinetic parameter. So clearance is basically a measure of the body's ability to eliminate drugs. Okay, a measure of the body's ability to eliminate drugs. So the volume of distribution from which all the drug is, I mean a volume, sorry, a volume of fluid from which all the drug is removed per unit time is basically what is known as the clearance. So there's a formula for clearance, and that is the rate of elimination over the drug concentration. Now, elimination of the drug from the body may involve processes that will occur in the kidneys, the liver, the lungs, and other organs. So basically, once this drug is absorbed, it is distributed and metabolized, then it has to be eliminated from the body. It has to be cleared, and that is what we are discussing here. Now, the two major processes that are involved in clearance is one, hepatic metabolism, where the liver will convert the drug into an inactive form, and then we have biliary excretion, and then uh, biliary excretion, of course, that is after the drug is metabolized by the liver, it will be excreted and released via the bowel. Then the bowel will be released into the gastrointestinal tract, and then the drug will be excreted through feces. Then renal filtration, basically, as drugs at the level of the kidney. Remember the processes that take place in the kidney during urine formation. We have pressure filtration, okay? Then we have selective reabsorption, and then we have secretion of substances into the renal tubules, okay, or into the loop of Henle. Some substances will not be filtered, but they'll be secreted straight from the blood vessels or at capillary level into the renal tubules. Okay, so that process of secretion will also involve secretion of drugs into the urine that is being formed from the body, and so those drugs will be eliminated. Now, total body clearance is the sum of all individual organ clearance. So when we put together the clearance that is taking place that is occurring in the kidneys, and also that which is occurring in other parts of the body, such as the GIT, okay, the skin. Remember that the skin also clears out some of the drugs as you sweat. Then some of the drugs will be cleared even through the lungs as you are breathing. That vapor that comes out may actually contain some drugs, depending on the type of drug that it is. So factors that affect drug clearance include blood flow to the clearing organ. So if there is adequate blood flow to the clearing organ, such as the kidneys, then it means the clearance of that drug will be high. Binding of the drug to plasma proteins. Now, remember I had mentioned that most of these drugs travel bound to plasma proteins such as albumin. And albumin is one of the major proteins that transport drugs and other substances around the body. They bind them and then move them around. So, if you don't have enough carriers, I'll call them carriers, if you don't have enough proteins to carry these drugs around to their site of clearance, then the rate of clearance of the drug will be affected. Okay. Then activity of processes responsible for drug removal, such as hepatic enzymes. If a patient has a deficiency or defects in hepatic enzymes, those drugs that are metabolized in the liver exclusively, it means that only the rate at which those drugs will be metabolized will be low because there isn't a sufficient amount of enzymes to break down those drugs within the liver. Then also the glomerular filtration rate and secretory processes. Basically, if a patient has kidney malfunction, then if you give them a drug that is completely cleared through the kidneys, then the rate of clearance will be very low. What that means is the drug will persist within the system, and when you give an additive dose, then you may easily push this patient into toxicity. So maybe there could be need to reduce the dosage of the drug in patients that have renal impairment. So we've discussed absorption as a pharmacokinetic parameter. Let us now discuss the distribution of the drug. So distribution is basically the dispersion or dissemination of substances throughout the fluids and tissues of the body. Distribution. Okay, taking this drug throughout the body and the fluids and tissues within the body so that it can actually exert its effect. So some drugs travel bound to proteins, in brackets I've said albumin, and can only exert their effect when they are released from the protein. A very important point that I had already mentioned. Remember that these drugs will require albumin to be transported. So in patients with hypoalbuminemia, then the distribution of drugs will also be low. It will be affected. Now, when the drug is still bound to plasma albumin, it cannot exert its therapeutic effect. Um, it needs to be released from this albumin in order for it to exert an effect. So as the drug circulates through the body, a certain level must be maintained for the drug to be effective. So we have the minimum effective concentration. The minimum effective concentration. You need to have the drug at least at the minimum effective concentration within the blood in order for it to exert its effect. It means that when the percentage of the drug or the amount of the drug falls below that minimum, then the drug will not be able to exert its therapeutic effects. Okay. So should the level of that drug in the bloodstream, again, if it goes very high over the therapeutic level, then toxic symptoms will develop. That means these drugs are actually calculated to be dosed at a certain frequency so that we just maintain the drug within the therapeutic levels. Okay. We don't want to be below the minimum effective concentration. Again, we don't want to go into the toxic level. We want to maintain it at the optimum. Okay, we want to maintain it at the optimum level where we can exert the maximum effects on the target tissues. Okay, so that is about distribution of the drug. Now, as nurses, this is important for us because It means that if we are missing certain doses of the drug, let's say drug is supposed to be administered 3 times a day or 8 hourly, and then we give in the morning at 6, we don't give at 14, we give, let's say, at 11 hours. What are we doing? It means that the amount of the drug that is still available to the tissues is still high. Then we give this drug much, much earlier. It means that that additive dose may be pushing the patient towards toxicity. That is why it is important for us to give drugs according to their prescription. If it is 8 hourly, the drug has to be administered 8 hourly. Otherwise, we risk pushing the patient either into having the drug below the minimum effective concentration, or will push the patient into toxicity. Okay. What about metabolism as a pharmacokinetic parameter? So, metabolism is also called biotransformation. Now, this is the process by which a drug is converted by the liver into an inactive compound through a series of biochemical reactions. We've actually briefly talked about metabolism, and it is basically the conversion of this drug into an inactive compound. This can occur in the liver, but also it can take place in the lungs, it can take place in the GIT. Okay. Now, patients with liver disease may require lower dosages of a drug that is detoxified by the liver, or we may have to give them a drug which does not undergo metabolism in the liver. Because what that means is that if this drug cannot be metabolized, then it will remain in its active form within circulation for a longer period, and that might cause toxic effects on the patient. So once a drug has been made available to the tissues, when that blood which is carrying the drug reaches the liver will break down that drug into an inactive substance. Then that inactive substance will be excreted or eliminated or cleared from the body. Now, the kidneys, lungs, plasma, intestinal mucosa also aid in the metabolism of drugs. So some drugs will be metabolized, like I said, in the lungs, some just within plasma, while others in the intestinal mucosa will also be converted into inactive compounds. And I've said the purpose is that after this drug is converted into inactive compounds, then it will be eliminated from the body. Excretion. Okay, this is the elimination of the drug from the body. So after the liver inactivates the drug, it can be the liver, or it can be the kidneys, or even the lungs, but whichever body surface that will inactivate this drug, after the drug is inactivated, the kidneys will excrete the inactive compound from the body. Some drugs may actually be excreted unchanged by the kidney without liver involvement. Okay, they'll come out unchanged, especially those drugs that would like that this drug exerts its effect, for example, on the kidneys themselves. For example, we have urinary antiseptics, drugs such as methenamine mandylate, drugs such as trimethoprim, okay, drugs where we want this drug to work on the kidney. So it means that this drug will have to be in its active form at the time it is reaching the kidney. The liver should not have a significant effect on that drug, so it might be excreted in its unchanged form by the kidney. The liver will have not acted on it. So drug actions or drugs have an onset, okay? There will be a time when the drug begins to work. For example, if you administer a drug orally, let's say, for example, paracetamol, it will take at least 20 minutes before that paracetamol begins to work. So that is the time of onset of action. Then there's the peak action, and then there's the duration of action. So what is the onset of action? When the concentration of the drug at the site of action is sufficient to start a pharmacological response, then we'll call that point the onset of action. It will be influenced by the route of administration, the dosage, the rate of absorption, the distribution, and binding to receptor sites. That's the onset of action. Okay. When you administer insulin subcutaneously, okay, it won't begin to work immediately or within seconds. And depending on the levels of hydration of your patient, maybe it will take at least some good 5 to 10 minutes before the drug can actually begin to exert its effect. When you have administered an oral hypoglycemic drug, for example, such as metformin, metformin won't begin to work immediately. It will take at least some 20 minutes before it begins to work. So the time at which the concentration of the drug at the target tissue is sufficient enough to begin to exert that therapeutic response, we'll call that the onset of action. Peak action, this is the time at which the drug reaches the highest concentration on the target receptor site, thereby inducing the maximal pharmacological response for the dosage that has been given. So the concentration of the drug at the target site will be increasing gradually until it reaches the maximum concentration that can exert a therapeutic response. So at that time, we'll say that is the peak action. Okay. So you may find perhaps with an oral administration, it may be 1 hour to 1 hour 30 minutes after you administered the drug, then the drug will be at its peak concentration at the target site. Okay. Then the duration of action, this is how long the drug has a pharmacological effect. That is the duration of action, for how long the drug will remain active, or for how long the drug will have a pharmacological effect. So points to note are that patients with kidney diseases may require a dosage reduction and careful monitoring of kidney function. Okay, so when we're administering a drug to patients that have kidney problems, please ensure that we monitor kidney function and so that we can see how effective the kidney is, and that it will be able to indeed eliminate this drug. For children, children have immature kidney function, and so they may require dosage reductions and kidney function tests frequently to see how well their kidneys are working. It is important for us as nurses to always monitor kidney function, especially, and also the dosages. Please ensure that you calculate the correct dosage for children, because you may easily send these children into toxicity. The same will apply for older adults, because older patients, okay, for example, those in their 60s, 65, they have diminished kidney function and they require careful monitoring and lower dosages. So when you have a patient, an elderly patient on with a chronic condition, and they're taking drugs that are eliminated by the kidney, metabolized by the liver, frequently we need to monitor kidney and liver function. Okay. Then other drugs are eliminated by sweat, breast milk, breath, or by the gastrointestinal tract in the feces. I think I had already explained that. Lastly, among these principles, we'll discuss pharmacovigilance. Okay, pharmacovigilance. Now, pharmacovigilance basically is defined as the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects or any other drug related outcome. Now, this is an important activity for us as nurses, because when we administer these drugs, we need to monitor our patients to see whether we are able to detect any negative effects that the drug is exerting, any undesirable effects, okay, on the patient. Um, so we need to assess these patients and we need to be able to prevent adverse effects. What are the aims of pharmacovigilance? To improve patient care and safety in relation to the use of medicines and all medical, paramedical interventions. So we monitor patients so that we can indeed withdraw this drug or we stop administering it in case it is exerting undesirable effects that will make the administration of drugs safe, to improve public health and safety in relation to the use of medicines. Also, to contribute to the assessment of benefit, harm, effectiveness, and risk of medicines, okay, encouraging their safe, rational, and more effective use. Also, to promote understanding, education, and clinical training in pharmacovigilance and its effective communication to health professionals and the public. Lastly, I'll just briefly talk about how drugs are classified so that when you're administering drugs, you will know uh, how these drugs are actually administered. Um, I mean how they are classified. So a drug class is basically a term that is used to describe medications that are grouped together because of their similarity. So drugs can be grouped together by virtue of their similarity. Now, there are four dominant methods of classifying drugs. Firstly, drugs can be classified by their therapeutic use, meaning the types of conditions that they are used to treat. So, for example, if these drugs are used to treat psychosis, they'll be called antipsychotics. If they are used to treat bacterial infections, they'll be called antibacterials. Okay? So that is classifying drugs by their therapeutic use. Drugs can also be classified by their mechanism of action, meaning the specific biochemical reaction that occurs once the drug is taken. For example, we have drugs classified as angiotensin converting enzyme inhibitors, meaning this class of drugs is based on the mechanism of action. How do these drugs work? They inhibit the drug angiotensin converting enzyme. They inhibit the enzyme angiotensin converting enzyme. Examples of these drugs are like captopril and enalapril. Okay. Drugs can also be classified by their mode of action, meaning the specific way in which the body will respond to the drug. For example, drugs can be classified as vasodilators. Why? Because when these drugs are given, the body will respond by dilating its blood vessels. For example, hydralazine. Drugs can also be classified by their chemical structure. Okay, so based on the chemical components of that drug, for that particular drug. For example, sulfonamides. Okay, sulfonamides, cephalosporins, those drugs are classified based on their chemical structure. So based on these diverse classification methods, some drugs may actually be grouped together under one system, but not another. But in other cases, you may find that a drug may have multiple uses or actions and may be included in multiple drug classes within a single classification system. For example, a drug can be called an ACE inhibitor. At the same time, it will also be called an antihypertensive if we classify it based on therapeutic use. Okay. Then, if we classify it based on the mode of action, the same drug, we're going to call it a vasodilator. So you may find one drug will belong to several classes depending on which classification system you decide to use. So we are going to end here, and Your assignment will be to read on prescribing, read on the principles, read on rational prescribing, and then read just this brief explanation on drug interactions. So thank you very much. I believe you have these notes, but I'll still resend them so that you can read on the remaining components.